I was asked to speak today because I work at Kaiser Permanente in Santa Clara, and for those of you that don't know, Santa Clara County is in the Bay Area. It's the county that contains Palo Alto, where Stanford is, and the largest city is San Jose. A lot of Silicon Valley is located here in Santa Clara County. So this slide is from our public health department and the epidemiologist there, showing TB case rates in different counties of California in the year 2007. And Santa Clara County had the third highest rate of tuberculosis cases in the state of California. And as you can see, it's very close up there with San Francisco. Just to show people a map of our county, this is a map, again, from the public health department showing the concentration of TB cases, and the highest rate of TB was in the central part of San Jose and in a city called Milpitas, which is in the north part of the county. Coincidentally, that's also the parts of the county where a lot of foreign-born persons live. And this is, from the public health department, a pie chart showing the different ethnicities of the various people that were diagnosed with TB in the year 2007. And two countries accounted for the majority of cases, but there's a smattering, just like in many places. So I have a polling slide for people listening, and this is for people that take care of patients, pediatric patients that have latent TB. What do you think is the most common barrier that parents will express if they tell you that they refuse latent tuberculosis treatment? Okay, so I'm going to go ahead and close these polls and show you the results. And just as I had expected, there's quite a smattering of different responses. I've heard all of these things when I've dealt with parents that are expressing concerns about giving their children INH. And probably the most common response that I hear as well is that the parents don't really believe that the PPD is valid. A positive PPD they can claim that it's a false positive because their child received BCG vaccine. But a lot of parents don't realize that the response to BCG vaccine does wane over time. And we try to educate the parents about that issue. Some of them continue not to believe us and not to trust us about that fact, but sometimes we'll even show them some data about the percentages of people over time. Unfortunately, there's not a lot of really great data in kids, but there are some. And we tell them that usually by the time a child is 4, that a positive PPD usually means that they do have a true latent case. We do hear some people say that they don't believe that their child has latent TB because they have normal x-rays and the child has no symptoms. And again, it's the process of educating them that actually it's a hidden infection. It doesn't cause symptoms. And some people don't make a link between the purpose of giving INH and the idea of preventing active TB in the future. Even if they believe the other two things, a lot of parents may not really make that connection. So sometimes here our internists at Kaiser will ask me, how do you get pediatric patients to take INH? How do you get the parents to believe that this is a good thing for them when we have such a hard time getting the adults to do it? And I do think there are some important differences between treating children and teens for latent TB than for adults. And it's a lot like chronic illnesses and vaccines. Sometimes parents perceive a greater benefit to giving the same exact intervention if it involves their child. And I think that they are more concerned sometimes about their children's health that way than their own, unfortunately. And there's a similar phenomenon that seems to happen when we talk with them about vaccines, giving an 11-year-old Tdap. Now our state requires that, whereas if you try to tell a 40-year-old adult that's been healthy, getting Tdap, they're likely to decline. And the same with chronic medications for diabetes like insulin and monitoring. Parents tend to be more concerned about their kids. And in a similar fashion, we can see a breakdown in compliance when there's a socioeconomic barrier, if there's a financial barrier, for example, if there's cultural or language issues that interfere with it. And in particular, teens just have so many different things going on, and they are rebellious many times, and it's harder to get them to take it. So we developed an interest in this program in the year 2005. We had just started working at the new facility here in Santa Clara, and we had a case of an infant whose parent was a healthcare worker, that had TB acquired from an uncle, a young uncle who was healthy without HIV, and the uncle infected multiple family members. And in the process of evaluating that family, we learned how much time it takes to do this, to treat people in the context of active cases. And it inspired us to kind of decide, why don't we make a program in our HMO to treat children with latent TB while they're young, because if we do, and if they complete it, then as adults are much less likely, 96% less likely actually, to develop active TB. So this program was conceived by a colleague of mine named Elizabeth Copeland, and we had a nurse that became interested in it because she had a background in public health. So currently it's run by just myself and the public health nurse. Our nurse is named Chris Rodriguez. We enroll children that have positive skin tests, usually just tested for school entry and not referred for other reasons. And only those children that didn't have exposures to active TB cases were eligible for the nursing follow-up. The ones that had known exposures to active cases, I usually would see them myself, particularly because I really wanted to make sure they took the medication, and they were sort of had a special focus of my energy, but the rest of them were sort of enrolled in this program. And we enrolled them at the time that their new positive PPD was read. The way that it worked was we had a licensed vocational nurse, several of them that would read the positive PPDs. They would then order a chest X-ray in my name. They'd order 2 views and forward the results to me. Currently, our HMO has electronic X-rays that we can forward to each other fairly easily, but this could also be done before we had that technology, because we did actually do it for a few years before we could easily forward those results. I reviewed those X-rays, and then I would decide whether they needed to have repeat films if they were unclear, if I thought they had active disease and needed to be referred to me, or if they had normal films and could just proceed with latent TB treatment, all things being equal. And then once I would forward the chart to their primary care provider, the provider would then order the INH for 9 months. The way that it works in our system is they have to get a 3-month supply and 2 refills, because that's the most we can provide them. And I use a chart from Ann Luffler to help them determine the dose, and we usually try to use tablets rather than liquid, just like Ann Luffler recommends. And then the provider will then forward a chart to our TB nurse, Chris Rodriguez. So this is where the actual follow-up begins. So Chris gives the patients her phone number, and she'll talk with them a little bit about their perception of INH, and we'll talk with them through any suspected side effects that they think that their child might be having, and talk with them about the actual risks of about 1 in 10,000 developing hepatitis. That's reversible. It's a very low risk in children, and the risk does increase, of course, with age. But it's not in the pediatric age group. It's mainly people above the age of 35 years or people with active hepatitis. She calls them 1 month after their INH is picked up, and she asks the parents how everything's going, and she'll sort of assess any barriers that they report and the missed doses. And if things are going well with that, she sort of just tells them she's going to call them again in 4 months, the time of their first refill, and she again asks them the same questions, checks to see if they've actually refilled the bottle. She can look from an electronic database and see that. And she'll ask me to call some of the parents myself if she sees that they have a lot of concerns, and sometimes I'll even bring them for an appointment as well. Then the third phone call is around 7 months, when they should be getting their last refill of the medicine, and a final call around 10 months, sometimes a little bit longer than that, to make sure that they report that they've completed it. We do suspect that there's quite a few patients who go through the whole 9 months, but who don't return our phone call at the 10-month mark. And I'll show some data about our completion rates in the next slides. So the outcomes we've seen among the children enrolled in this program, a lot of the patients don't complete the telephone follow-up. That doesn't necessarily mean that they haven't completed the 9 months of INH. But we do get some people who are very open about their decision not to take it. Some just openly refuse within the first visit or even the first 3 months. If we can get them beyond 3 months, a lot of them seem amenable to completing it, though. Some patients move, of course, and are otherwise lost to follow-up, just like in any other LTBI program. And We do have patients where they've had BCG fairly recently. We've had a few kids who got it when they were 2 or 3 years old and then came and got tested for the 4-year physical and had a positive test. And for those, I've gone ahead and ordered QuantiFERON TB Gold on them. And we found a handful of cases that we thought were false positives, and we decided to defer treatment in those and retest them when they're 11. So even with the different barriers and even with people who do refuse, we have seen the rates of completion of the 9 months rise since we started this program. This slide just shows the past 3 years of data for the program, and in 2009, the first year shown, we only documented about 15 patients completing the LTBI treatment. Chris estimates that there may have been double that amount for each of the years, though, in terms of the ones who she thinks actually probably did complete but didn't complete the 10-month follow-up phone call. They didn't call us back. And as you can see, there were some patients who outright refused, and we had just a few false positive cases that were confirmed by QuantiFERON TB Gold as negative, but having a PPD greater than 10 millimeters. And this is for the most recent year. We had about 15% actually complete the 10-month follow-up phone call. It may have been as high as 30% approximately if we consider the number of refills that were filled for the 9-month mark. And unfortunately, we still have a little ways to go, but I think that we're making some headway. Part of our success, or part of our ability to get this program started and maintained, was making sure that our pediatricians had buy-in, that they believed in the purpose of the program, and that, of course, involved education. We had a couple of TB experts from our county health department come and give talks, including Sundari Mace, who now works at CDC, and now we have Julie Higashi, who I work with closely. She helped provide materials that I gave to our pediatricians about the nature of latent TB and the nature of TB in the U.S., including the fact that the vast majority are foreign-born cases. And so we educated the pediatricians about the time when people are infected, that they're infected in childhood. We try to emphasize that the time and cost of treating a latent case are much less than the time and cost of treating active cases and tracking them down. The amount of time is quite enormous for a child. We also try to get them to understand the actual risks of the INH, which are quite low in kids, and the benefit of getting them to take it, and sort of saying this is time well spent. And we try to get people who are resistant to treatment to call upon me, or for the doctors to refer those to me. A lot of those now I handle just by calling the parents, and I say, well, I understand your concerns, and I try to go through those things with them on the phone. And it doesn't take a terrible amount of my time, but a lot of times I can get them to think differently about it. The program doesn't depend on the individual doctors referring them to me, because any positive skin test is sort of automatically referred to me because of this X-ray process that I talked about. And I do think that it's important that the pediatricians believe that the program is good, but I also am kind of glad that they don't have to individually refer every single patient to me for it to occur. Part of our success in getting people to do this again is the interaction we've had with public health, in particular our controller, but also the different caseworkers, the case managers, and the actual individual DOT workers that correspond with us about how things are going. If we have patients that are getting DOT, usually the parent, the kids can sometimes have the LTBI given by the DOT worker. And we talk with them about individual differences such as adults with cavitary disease or drug-resistant TB, and we sort of update each other back and forth. If I know, for example, that the adult has a resistant case, sometimes I'll get the sensitivity report before the public health department does, and I can call her and say, uh-oh, this person's resistant to INH, we probably need to think about something else. And vice versa, Julie sometimes will tell me, we found out today that this parent actually has 2 other children that they've never told you about. So we have this kind of interaction where we kind of help each other get more data. And this will be my final slide about how we've maintained the program over the past 5 years. And I think sort of key to keeping a program like this in an HMO and getting it going and sort of keeping it going from year to year is having interest on the part of the physician that runs it and the nurse in particular, because she's doing a lot of the calls. I don't think necessarily that the physician and the nurse have to have special training in TB. They don't have to be an ID specialist or a pulmonologist, but it does help for them to know that. And for people who are interested, having them attend CME programs on TB can be a big help. Both of us have individually attended courses at the Curry Center in San Francisco. I wanted to learn about case management, and I actually attended the case manager's course just to learn about how that operates and how people communicate, and I learned a great deal from that. And Chris has attended a program on latent tuberculosis treatment, and she also brought back a lot of helpful tips about dealing with the parents and about the actual risks of the INH and how to restart patients who have not been compliant. So our nursing management and the physician leadership of our organization do support our time with this, and we estimate that it probably only involves about, at the most, 40 to 60 minutes per patient per treatment course. It's not a terrible amount of time. If we have about 150 patients a year, that's approximately 12 to 18 workdays, so that's probably an overestimate. And we're sort of just thinking, what is the most amount of time we spend per patient, and that's our sort of overestimate or large estimate of what that might be. I do think that having electronic records is a big help, and it's particularly helpful for looking at the x-rays and tracking the pharmacy records, but it can be done without that. And before we had our computer system up, we did a fair amount of this work without having access to electronic records. And we really just sort of had the motivation that we wanted to see fewer active cases of TB developing in adults later. A big inspiration to the people that developed the program was a document published by the Institute of Medicine called Eliminating TB, and a lot of you are familiar with it. And I think that it's a good reference because they present very useful arguments for treating latent TB early and the safety of doing it when people are young. So I'm going to go ahead and pass the baton to the next speaker, to Dr. Lindquist, and to Chris Jeffress over at Kitsap County in Washington.